Okay, thanks, Dan. And I know you really want to stay on time, but in my opinion, this is probably the most important talk. Come on. For routine clinical practice. You know, I could fib to the organizer saying that I was waiting to prepare the slide presentation at the last minute because I was waiting for all this data to come in that I'm going to show you. But everyone knows that that would be a fib, that I just am always procrastinating. So I'm going to talk about the state of the art for the treatment of AML with the understanding that everything has changed in the summer of 2017 with the approval of 4 new drugs, led the way by midostaurin, Rydapt for FLT3 positive AML, followed a couple of months later by 2 other drugs, enasidenib or IDIFA for relapse refractory IDH2 positive AML, as well as CPX-351, the liposomal daunorubicin cytarabine, or Vyxeos, for secondary AML. And then just a couple of weeks ago, gemtuzumab ozogamicin, it is back, Mylotarg, for CD33 positive AML. So we have to consider how are we going to incorporate these things into our armamentarium. And so I'm really going to focus, however, on just 3 of those drugs because I don't have enough time to do justice to all of them. Probably don't have enough time to do justice to the 3 I'm going to choose, which is the initial therapy for AML. I want to thank the organizers for not asking me to talk about older AML. I feel like I'm getting typecast. I feel a little bit like Jean-Claude Van Damme, you know, always the same character. I can talk about other things. Here are my disclosures. I want to point out, relevant to this discussion, that I have been an advisor and consultant to Jazz, to Novartis, and to Pfizer. Okay, so this has been what we have been doing for the last 40 years or so. We have been making a diagnosis of acute myeloid leukemia and very rapidly starting induction chemotherapy, which has been a combination of an anthracycline and cytarabine, in the vernacular 7 and 3, or if you're dyslexic, 3 and 7. That's about the only variation we had. And then, hoping that the patient gets into a complete remission, which occurs in about 50 to 75% of patients, they would then go on to post-remission treatment with the idea of inducing a prolonged disease-free survival. And we would use a risk stratification to decide between consolidation therapies like high-dose cytarabine or allogeneic stem cell transplantation. And this is what we've done. The risk stratification included karyotype analysis, now somatic mutations, and you'll hear later about MRD. So where are we with 3 and 7? So this is what my talk was going to be like a few months ago, just looking at the nuances of 3 and 7. So I want to point out the SWOG study that was presented by Guillermo Garcia-Manero at ASH in 2016. This was a randomized phase 3 study that asked the question, did idarubicin in high-dose Ara-C with or without the HDAC inhibitor vorinostat perform superiorly to just our standard 3+7 followed by HiDAC. The dose of the daunorubicin you can see here was 90 per meter squared for future reference. There was no difference in response rates. There was at least a trend at 60 days for an increased mortality with the idarubicin and high-dose cytarabine arms compared to 3 and 7. And there was no difference in overall survival. Now, in this study, 3 and 7 followed by HiDAC actually led to a better survival in the CBF translocated AML patients compared to idarubicin and high-dose Ara-C. But I do want to point out, in the original MD Anderson study, CBF AML was not included, was not treated with idarubicin and high-dose Ara-C at that institution. But for future reference, I want to point out that in the poor risk karyotype group, despite the use of idarubicin and dose intensification of cytarabine, there was no difference in overall survival for that poor risk karyotype group. So let's look at the anthracycline. We know back in the 80s there were 3 studies comparing idarubicin to idarubicin to daunorubicin. In this meta-analysis, it seemed like there was a benefit in terms of remission rates for idarubicin over daunorubicin in the younger, but it was not seen in older patients. But it became clear from that evaluation that the daunorubicin was not being given at a biologically equivalent dose to the idarubicin. And so we now go on to the dose-finding experiments or studies for daunorubicin in younger and older AML patients. ECOG led the way with the ECOG 1900 trial, comparing daunorubicin at 90 for 3 days versus 45 for 3 days. And as you know, there was a higher remission rate with the higher dose daunorubicin, 71% versus 57%. There was an improvement in survival. However, in subset analysis, that benefit was only seen in patients with favorable risk and intermediate risk cytogenetics, again, not in the unfavorable cytogenetic group. So intensification of daunorubicin did not benefit those patients. And in a subsequent analysis, an interesting observation I'm going to come back to is that patients with a FLT3-ITD mutation did seem to benefit from the daunorubicin at 90 versus 45. Well, many investigators and clinicians in the United States said, well, we don't use 45 per meter squared of daunorubicin, we use 60. And so we thought the study, AML-17 from Dr. Burnett and colleagues in the United Kingdom might actually solve this problem for us, because they did a large randomized trial of daunorubicin Ara-C at either 90 versus 60 per meter squared. And what they found was no difference in CR rate, and no difference in overall survival or incidence of relapse. Now, what confounds the interpretation of the study for us in the United States is that we don't typically give a second cycle of an anthracycline-containing regimen, whereas that was given to all patients who had anything other than poor risk AML. However, in a subsequent analysis and further follow-up of the study, they also saw a benefit of 90 over 60 for patients with a FLT3-ITD or a tyrosine kinase domain mutation. This was seen not only in overall survival shown here, but also in relapse-free survival and cumulative incidence of relapse. Well, I used to get around the problem, and I still do, about the daunorubicin dose by just substituting idarubicin for it. The Japanese Leukemia Study Group had previously published a study of 50 times 5 of daunorubicin versus idarubicin showing equivalence, but to get it even closer to home, they've recently published in JCO this study of idarubicin at 12 per meter squared for 3 days versus daunorubicin at 90 for 3 days, with cytarabine at 200 milligrams per meter squared, showing no difference in CR rates, no difference in overall survival, and no statistical difference in relapse rate or event-free survival. However, again, I'm going to come back to this point. The higher dose daunorubicin appeared to benefit patients with a FLT3-ITD mutation. The numbers are quite small in this subset analysis, but you can see an improvement in survival with the daunorubicin dose arm, as well as event-free survival. So what have we learned? Daunorubicin 90 is superior to daunorubicin at 45 during induction. Daunorubicin 90 does not appear to improve outcomes in younger patients compared with either daunorubicin 60, although you can argue that those patients in the MRC study received 2 rounds of daunorubicin, and definitely isn't better than idarubicin at 12. However, in a couple of different data sets, daunorubicin at 90 did appear to benefit patients with AML with a FLT3-ITD. And then, really importantly, I think for younger patients with poor risk cytogenetics, there is no randomized data that shows that intensification of cytarabine or higher doses of daunorubicin during induction therapy actually benefit those patients. Although there are many of us out there who see these patients with secondary AML who are younger with poor risk karyotypes who will want to give our favorite regimen for refractory AML, like Ida-Flag, or what's the new one, Clag-M, or M-Clag if you're dyslexic as well.